Hi, everyone. So happy New Year to all of you. Great to have you with us with this webinar entitled How I Diagnose and Treat Monogenic Cause of Inflammatory Bowel Disease. So I'm a pediatric rheumatologist in Lyon, and I'm very happy to co-chair the session with Martine Perjean, IPOP president, and Julia Koholz, junior immunologist from Dresden. So don't forget to ask your question in the question tab. And I give the mic to Julia.
Thank you, Alexandre. So welcome everyone also from my side. And thank you for joining us for another Tuesday Lunch with Rita webinar on how I diagnose and treat monogenic causes of IBD. As Alexandre already said, I'm a junior immunologist or immunologist to be working in Dresden, and my great interest is in monogenic inborn errors of immunity, and it's my great pleasure to be your moderator today. To organizational things first, it would be very nice if you use the chat to let us know where you're joining us from. And the second thing is we want this to be an interactive session. So please do use the question tab, which you can find on the right-hand side of your screen to ask questions at any time. And also you can do it during the presentation and also during the Q&A session that will follow. And now it's my great pleasure to welcome very talented, or two talented speakers, but I will introduce the first one. This is Daniel Kotlarz from Germany. And Dr. Daniel Kotlarz is a pediatrician and researcher specializing in the immunogenetics of pediatric inflammatory bowel disease. And he earned his MD and PhD from Hanover Medical School, completed advanced postdoctoral training in Munich and Boston, and now he leads the research group on immune and genetic signatures of pediatric IBD at the LMU in Munich. And he will soon continue his research there as Heisenberg professor. His work focuses on identifying molecular pathways and genetic markers in pediatric IBD and to develop targeted therapies. Dr. Kotlarz is the Heinz Meyer Leibniz Prize winner of 2020, and he was also honored with the Eco Pioneer Award in 2023. So you see, he's done a lot of this field, and now we're very happy to hear your brilliant talk. Thank you.
So good afternoon. Thank you very much, Julia. Thank you very much for the organization team for the kind invitation. It is a great pleasure to provide you an overview of our translational research on very early onset IBD, together with Alexio Muise, who's a good friend and mentor of mine. So in principle, we follow a functional genomics approach to improve diagnostics and therapies for children with devastating diseases. So since this is a diverse audience, I have few basically background slides. IBD represents a complex and multifactorial disorder, and the pathogenesis of IBD involves different components, including the environmental factors, the microbiome, the defective epithelial barrier, and immunological dysregulations. And all these factors must intersect in multiple ways to become clinically apparent in genetically susceptible individuals. And to shed light on molecular factors controlling intestinal homeostasis, we have focused on the analysis of children presenting with apparently monogenic variants due to the fact of a severe and very early onset of IBD. So, but what is very early onset IBD? And to provide you a short introduction, it is defined by the disease onset with a cutoff below 6 years of age. Even though it is a rare disease, the incidence of BO-IBD has dramatically increased over the last decades worldwide. Notably, a higher frequency of unclassified cases can be observed in comparison to adult IBD, and it is known that young children with IBD have a distinct, more often life-threatening disease refractory to conventional treatments. And based on these distinct phenotypes and early onset, these patients were considered to have more likely a familial disease in contrast to adult forms with substantial contribution of environmental factors in disease pathogenesis. So as indicated by these excellent reviewed metadata by Alexio's team, the group of BO-IBD patients are not treated optimal and not systematically, as many children have to undergo bowel resection, show ineffective response to biologics, or no improvement even after hematopoietic stem cell transplant. So correspondingly, the next slide illustrates the characteristic progression of inflammation and digestive damage in VOIBD patients with the risk of developing fistula abscesses, stenosis, then they have to undergo surgery, and then they develop additional severe complications. And the overall goal of our study is to decipher the molecular causes of VOIBD during the window of opportunity to employ genomic medicine to provide, at the end, rational arguments for development of personalized treatments. So initially, my interest for this research was raised by a single patient who developed IBD within the first weeks of life, who showed a very severe refractory disease with horrible perianal disease, and he had to undergo an odyssey of long-lasting and frequent hospitalization. And at that time, in collaboration with Bodo Grimbacher's team, using homozygosity mapping and classical candidate gene sequencing, we could identify IL-10 receptor deficiency as the first truly monogenic cause, so a single inherited genetic defect of IBD. Our functional studies at that time have already provided the basis for functional diagnostics in clinical routine setting, as defective IL-10 mediated STAT signaling can be either detected by immune blotting, as shown here, or flow cytometry. Moreover, we could demonstrate that hyperinflammation of the monocytic and macrophage compartment is a critical pathomechanistic factor in IL-10 receptor deficiency, whereby several central inflammatory cytokines and pathways are activated and cannot be downregulated by IL-10. And these data indirectly provided also a rationale why monotherapies, such as TNF blockade, cannot really induce a sustainable remission in IL-10 receptor deficient patients. Importantly, our study was really a perfect example of clinical translation. So based on the knowledge of the underlying primary immunodeficiency, we could adapt a treatment from hematology, oncology, and immunology, and we could cure IL-10 receptor deficient patients by an allogeneic hematopoietic stem cell transplant. And as a representative example, one can appreciate the impressive perineal wound healing shortly after transplant. So taken together, our studies have really shifted the paradigm by demonstrating the importance of genetics for the clinical management of VOIBD. However, IL-10 receptor deficiency can be detected only in a minor proportion of patients. And in addition, in the clinical current settings, the following challenges provide additional level of complexity for diagnosing monogenic diseases in VOIBD patients. So first of all, it is a rare disease, so not every doctor seeing these patients has really observed or has already experienced handling VOIBD patients. It is a heterogeneous group of more than 100 plus monogenic entities associated with IBD, but in principle, and you know that better, we have to consider more than 400 monogenic pits. And VOIBD patients show a phenotypic heterogeneity regarding the clinical, laboratory, and endoscopic examination. So if you see that picture, it's very difficult to judge what could be the reason for the disease. And then at the end, in a similar way, the genotype-phenotype correlations are not well defined. And then, unfortunately, we have only a handful of functional tests in the clinical routine setting that help us to really provide a definitive diagnosis. So the next slide provides you with an overview how to proceed with diagnostics of patients with VOIBD. As a guideline, one can follow this stepwise diagnostic procedure. And first, the clinical anamnesis, the examination and diagnostic by endoscopy, histology, and clinical chemistry represents still a prerequisite, which also includes that more common differential diagnoses such as celiac disease, infections, and allergic colitis should be excluded prior to molecular diagnosis. And then you are the experts here as well, but moreover, basic immune workup is recommended to assess blood counts, lymphocyte subpopulations, neutrophil oxidative burst, and immunoglobulins at least, in order to exclude known and obvious inborn errors of immunity. And in case you have a suspicion of a definitive or specific disease, IPEX syndrome, IL-10 receptor, CF deficiency, as example, there are specific lab tests that can be conducted and genetic diagnosis can be confirmed by Sanger. However, in most cases, the routine workup has not revealed any molecular diagnosis and the functional tests do not exist. So we are going more towards using targeted gene panel analysis that can be used in many laboratories or commercial panels. But please take also or consider that there might be inherent limitations and that these do not cover all the knowledge that we have currently. However, in case of high QC and coverage standards, one could also consider genome-wide screening, which allows screening of the growing number of candidate genes and the analysis of novel candidate genes. And Alexio and me will provide some examples for that today. However, I would also like to underscore that these genetic studies often require established bioinformatics pipelines and subsequent experimental validation. So there is a requirement also for a large cohort that increases the probability of identifying genetic defects, thus making collaborations even more attractive. So to give you an illustration where we stand to unravel novel genetic signatures of VO-IBD, we have established here in Munich a large collaboration network within the VO-IBD consortium, together with Alexio Muise from Toronto and Boston. And basically we have analyzed one of the largest international cohorts. In Munich, we have assessed more than 1,700 patients. And as indicated by the simple pie diagram, in about 20% of patients, our genetic screen unveiled disease-causing mutation. Most of them in primary immunodeficiencies, but there were also novel candidate genes as listed here. And thus we could provide rational arguments for optimized and importantly even curative treatments such as hematopoietic stem cell transplant in case of primary immunodeficiencies in a significant number of patients. However, even though these are great accomplishments through our collaborative efforts, we still face the challenge that the majority of children lack definitive diagnosis. And today I would like to illustrate our genomic strategy by presenting a few practical examples how we try to close this gap. And I guess Alexio will continue on that. So starting point of the first project that I would like to present was an 8-year-old Malaysian boy born to non-consanguineous parents, presenting with refractory chronic active pancreatitis within the first month of life, accompanied by chronic diarrhea, failure to thrive, and severe perianal abscesses and fistula, as you can see in the images. And of note, just to summarize, our patient showed also a developmental delay with global brain atrophy and posterior leukoencephalopathy. So using a whole exome sequencing, we could identify a compound heterozygous variant in TGF-beta1 segregating with the disease phenotype as indicated by some sequencing, because the heterozygous mutation in the lab region was inherited by the mother, shown here, and the mutation in the mature growth factor domain was inherited by the father. And then it took us some years, but based on the close clinical resemblance, VO-IBD and a global developmental delay, we could identify 2 Pakistani patients in Norway harboring a homozygous TGF-beta mutation localized in the lab region of the pre-pro TGF-beta precursor gene. So to validate functional relevance if the identified mutation on TGF-beta lab biosynthesis and function, we conducted a series of biochemical assays in heterologous HEC293 T cells with lentiviral overexpression of the wild type or mutant variants. And in view of time constraints, I would like to summarize that various assays have suggested a defective secretion and bioavailability of mutant TGF-beta variants. And as a consequence, using a SMAD-sensitive luciferase reporter assays, we could detect an impaired signal transduction of all identified TGF-beta mutants in comparison to wild-type cells. As an immunological correlate and potential critical mechanism of inflammation, CyTOF, so mass cytometry, revealed an impaired T-cell homeostasis in patient-derived intestinal biopsies in comparison to uninflamed controls and unrelated Crohn's disease patients, as indicated by reduced frequency of Th2 and Th17 cells, but in particular an abrogation of naive and memory regulatory T cells, which are known to be critical in controlling intestinal homeostasis. So taken together, this first part, our studies highlighted a non-redundant role of TGF-beta mediated signaling in controlling intestinal immune homeostasis and neurological development in humans. In the next research project, we could demonstrate that biallelic loss of function mutations in caspase-8 can cause VUIBD. Caspase-8 has been known as a genetic cause for ALPS before, and our next patient presented with IBD symptoms characterized by failure to thrive, again, bloody diarrhea, perineal disease, and anorectal stenosis in the first month of life. And colonoscopy and histology showed a discontinuous hemorrhagic colitis with deep ulcers as well as epithelial degeneration. Extra-intestinal manifestations included recurrent infections, hepatosplenomegaly, lymphadenopathy, and skin lesions, so pointing towards an immune dysfunction. And importantly, her colitis was refractory despite exclusive feeding and state-of-the-art anti-inflammatory treatment requiring an ileostoma at the age of 8 months and a colectomy at the age of 6 years. So to elucidate again the genetic entity, we performed a VES in this family and could identify a homozygous missense variant in caspase-8 as underlying disease cause. So considering that there might be an immune regulatory defect, we performed an analysis of peripheral blood mononuclear cells by highly dimensional or multidimensional flow cytometry, revealing lymphocyte dysfunctions as indicated A, by impaired differentiation of memory T cells, B, an altered T helper cell differentiation, and C, as well as defective B cell maturation with reduced class switched B cells. Furthermore, in addition to these lymphocyte dysfunctions, we could detect an altered inflammasome activity. In brief, inflammasomes are multimeric cytosolic protein complexes in innate immune cells that are triggered by pathogens or endogenous danger signals, and then through sequential activation of NLRP3, ASC, and caspase-8, so sensors, adapters, and executors, they mediate secretion of pro-inflammatory cytokines such as IL-1 beta. And to further evaluate the impact of caspase-8 mutations on inflammasome activity, we have established a heterologous Blair cell model, so macrophage-like cell lines with CRISPR-Cas9 mediated knockout of caspase-8 shown here, and then subsequent lentiviral reconstitution of either wild type or the mutant form. And interestingly, similar to patient cells, we could show that caspase-8 knockout or the transgenic expression of the caspase-8 mutant result in an increased IL-1 beta secretion upon LPS priming. So without the requirement of a secondary stimuli that is usually required for the secretion of mature IL-1 beta. And furthermore, this model helped us to assess the underlying mechanisms in greater detail, because blockade of either the NLRP3 mediated inflammasome activity by MCC 950 or necroptosis by NSA with small molecule inhibitors resulted in decreased LPS triggered IL-1 beta production, suggesting that both biological pathways might mediate increased pro-inflammatory responses in the absence of caspase-8 and present potential therapeutic targets. So since we are focusing on IBD, we also are interested in the intestinal epithelial barrier. And previously, caspase-8 deficient mice have been shown to develop a TNF-alpha-induced terminal ileitis associated with elevated RIP kinase 3 expression. However, our patients presented rather with a colonic inflammation, and importantly, TNF blockade failed to really induce clinical remission. So to study caspase-8 deficiency in epithelial cells, we generated intestinal organoids from intestinal biopsies of our index patient and challenged these with TNF or trail. And in contrast to caspase-8 knockout mice, we could not detect a difference in the frequency of cleaved caspase-3 positive cells upon stimulation with TNF-alpha between intestinal organoids from healthy donor or patient. However, whereas trail stimulation induced rapid and really robust caspase-3 cleavage, and thereby cell death in healthy donor intestinal organoids within few hours. Caspase-8 deficient cells were unresponsive to trail, so confirming abrogated caspase-8 mediated signaling. So to summarize that part, our studies indicate that caspase-8 plays an essential role in controlling inflammation, innate and adaptive immunity, as well as intestinal barrier integrity in humans. In another very exciting project, we have characterized RIP kinase 1 deficiency as another cause for VOIBD. And since this was very similar to caspase-8 deficient patients, I would like to just summarize that biallelic loss of function mutations in RIP kinase 1 result in a as well combined immune and epithelial defect characterized by lymphocyte dysfunctions, again, in particular, reduced class switch or defective class switch, enhanced inflammasome activity, as indicated here for increased IL-1 beta secretion in macrophages, and an altered TNF-dependent cell death response in intestinal epithelial cell models. And as a last example, I'm excited to share with you our more recent finding that our genetic screen identified also a homozygous in-frame deletion in the MD2 gene. It's called Li96 in a patient with VOIBD. This is our index patient, and a sibling presenting with severe pneumonia and otitis media. And notably, myeloid differentiation protein 2, which stands for MD2, is the indispensable co-receptor for TLR4 signaling, facilitating the binding to the gram-negative bacterial cell wall component lipopolysaccharide, short LPS. And first, our structural analysis suggested that the mutation might be associated with impaired N-linked glycosylation because it was located close to the consensus sequence for N-linked glycosylation. And to check that in greater detail, we performed an immunoblotting on a cellular model where we overexpressed C-terminal flagged wild type versus mutant MD2 and HEC293 T cells, showing that the mutant form showed a reduced molecular weight. And importantly, B, we could show that treatment of these lysates with glycosidases, such as PNGSF and ENDO-GH, result in a comparable mobility of deglycosylated wild-type and mutant MD2 variants, so really indicating defective N-linked glycosylation of mutant MD2. And as a consequence of this defective protein expression, we could show using various assays in iPSC-derived CRISPR-engineered macrophages that MD2 deficiency is associated with an impaired defective TLR4-mediated signaling with reduced phosphorylation of NF-kappa B P65 subunit, P38, and ERG in knockout and knock-in cells, in altered bacterial killing with reduced colony formation in gentamicin protection assays, and importantly, in impaired cytokine production, for example, as highlighted here for the anti-inflammatory cytokine IL-10 in response to E. coli and Salmonella, so gram-negative bacteria, but not gram-positive bacteria, as shown for Listeria. So indicating a bacterial handling defect. So Over the last years, in addition to these defects, IL-10 receptor, TGF-beta, caspase-8, RIP kinase 1, and CEP deficiency, more than 100 genetic entities have been reported as molecular causes of IBD, and there is a growing number. Notably, these genes have enormous relevance in both medicine, biology, and basically also immunology. And B, monogenic forms of IBD have uncovered diverse molecular mechanisms driving intestinal inflammation, so offering valuable insights into potential therapeutic targets. And thus, IBD patients provide also really powerful models to decipher complex IBD and immune-related diseases. So where do we stand regarding the impact of treatment? And here I would like to summarize and emphasize that differentiating molecular etiologies is already guiding genotype-driven precision medicine in monogenic IBD. This includes the curative approaches like hematopoietic stem cell transplant and the first gene therapy approaches, as well as pathway-targeted therapies and drug screenings, as Alexio might show you also in his slides. And in fact, monogenic IBD could serve as a pioneering model where targeted therapies establish proof of concept for precision medicine approaches. So despite these accomplishments, we still face the challenge that the majority of patients lack definitive diagnosis. And if we are honest, we do not understand the molecular mechanisms good enough, even in patients where we know the monogenic disease. And therefore, in the future, we propose to leverage our established infrastructures and collaborations to rather follow a systems biology-driven approach in order to define the molecular pattern mechanisms, the biomarkers, and the druggable phenotypes. Of course, as an entry point, we will continue with the genetic analysis, and we have optimized our workflows to faster provide clinically relevant genetic reports. But in a multi-omics approach, we aim to complement genomics by exploring the in-depth immune profiles, the single-cell transcriptomes, the proteomes, and the metabolomes. And finally, we employ state-of-the-art computational biology, machine learning, AI to integrate individual omics data sets to deconvolute key regulators and multi-scale networks of IBD. And this knowledge will be critical to improve diagnostics and define therapy stratification or personalized therapies. To illustrate feasibility and progress, so it's not only science fiction, I'm excited to share with you that we have already collected samples from more than, basically in principle, 150 patients, and that we have started to explore the single-cell transcriptome profiles of VOIBD. And integration provides a first VOIBD single-cell transcriptomic atlas, allowing detection of several common but also rare cell types among immune, epithelial, and stromal cells, as well as the cell type-specific transcriptional perturbation disease states. And in a preliminary approach, we can already use the data set to assess the cellular composition for individual patients. Remember, I have shown you that caspase-8 deficiency is associated with a defective B-cell maturation that can be clearly seen also in the single-cell data to detect inflammatory signatures and to generate initial patient stratification. But we also see that it will take a larger cohort to make more reliable predictions. And therefore, I hope that our talks will also stimulate existing collaborations and facilitate future collaborative efforts, because a strong bond between the immunology field and the gastroenterology field is needed here. So to conclude my presentation, I hope I could show you that diagnosis and clinical care is best coordinated by a multidisciplinary approach. Next generation sequencing technologies are recommended in clinical routine practice for genetic screening of VOIBD patients. Monogenic IBD should be also considered in patients. I have not talked too much about that when they are older than 6 years, but if they present with relevant comorbidity, immunodeficiency, extraintestinal manifestation, and or family history. And we believe that integration of multi-omics approaches is critical for comprehensive understanding of disease mechanisms and patient stratifications. And with that, I would last but not least like to acknowledge all the people involved in our studies, in particular our patients who are our driving motivation, the interdisciplinary medical teams at LMU Munich, but around the VO-IBD consortium. Here in particular, I would like to thank Alexio Muise and Scott Snapper, who are really great mentors and collaborators and friends. My team, my mentors here in Munich, Christoph Klein and Elise Gini, and of course our funding partners. And with that, I would like to thank you for your attention. I would hand over to Alexio for his talk.
Thank you so much, Dr. Kotlarz, for sharing your experience with us. I am Martine Perjean, the president of IPOPI, and the involvement of patients and patients association into educational program is very important in enabling the link the knowledge to the unmet need for patients. Now we will have the second talk of the day by Dr. Alexio Muise. Dr. Alexio Muise, you are a pioneer in precision medicine for children with very early onset inflammatory bowel disease. You received your MD and PhD from the University of Toronto and completed postdoctoral training at Sick Kids. You established the world's first multidisciplinary VEO-IBD clinic and co-directs several international research consortia. Your work focuses on uncovering genetic causes of pediatric intestinal disease, leading to personalized treatments and groundbreaking advancement in patient care. Dr. Muise's research has transformed VEO-IBD diagnostics and care, earning your prestigious award like the Young Investigator Award in Basic Science of the American Gastroenterology Association and Canada Research Chair in Pediatric IBD in 2015. Welcome, Alexio, and the screen is yours.
Great, thank you very much. I guess everyone can see my slides and hear me. That's okay?
Yeah, very good.
Perfect, thank you. So as Daniel mentioned, we study monogenic intestinal disease. There are two main categories that we're interested in. One is congenital diarrhea and enteropathy. Most of these patients will have a defect in the gut epithelium and present with diarrhea without inflammation. The other major group is a monogenic IBD, as Daniel already pointed out very carefully. We now know there are over 100 genes that may present predominantly with gut disease, and these can present anywhere from the epithelial to really any type of immune cell. In studies that we have done recently, we looked at the entire sick kids population with inflammatory bowel disease. So this were typical inflammatory bowel disease, age 0 to 18 years of age. And this was done by a fellow, Eileen Crowley, while she was at Sick Kids. And she basically identified that around 4 to 5%, or 1 in 20 of all pediatric IBD patients have a monogenic cause. And you can see here in the pie chart the number of different variants that were identified, and also the ages. While most children presented as infants, there were a large number of patients that presented up to their teenage years. Also in our lab, Ryosuke Nambu from Japan did a systematic review of the literature and found that there were 750 monogenic patients that were actually identified, and actually 10% of these patients presented as adults. So if we're only looking at the very young children, we are actually missing a large number of these patients. We recently completed a similar study looking at congenital diarrhea, which is just about to be published. And in this scenario, of a smaller number of patients, we actually found that 50% of patients were identified with a monogenic cause for their disease. So really, in my clinic, we have a number of patients, and almost all the patients that you see here basically have had a genetic cause identified, and most of them have gone to have bone marrow transplant and have been cured of their disease. At Sick Kids, we've established what we call the Precision IBD and Monogenic Intestinal Disease Clinic. And it's an interdisciplinary clinic where actually the PIs of the clinic are from GI, nutrition, and immunology. There are a number of embedded clinical and research projects. And we follow, unfortunately, over 150 patients who have developed IBD at less than 2 years of age. And out of the 150, only 10% of these patients actually have monogenic causes. So we're now trying to incorporate multi-omics, as Daniel explained, into our approach. So all the patients get whole exome sequencing, but now they're getting a number of other omics, such as bulk RNA-seq, microbiome analysis, and proteomics to see if we can actually improve this number of diagnosis. There's also a large number, we also have a sick kids team, a number of researchers that are studying individual patients. So our lab has identified a number of novel causes of monogenic intestinal disease, including ARPC1B, TDC7 deficiency, sick gain of function mutations, as well as PLEVAP, and a number of novel mutations. I think what's exciting is what Daniel mentioned. Through the large international collaborational efforts, we now know that there are a large number of diseases, and every year we're seeing multiple new diseases that are being identified. And again, our consortium is happy to collaborate with anybody who thinks they may have a novel form of monogenic intestinal disease. So I had to go through a number of cases. So this is our first case. One of our patients, her name is Lila, and she presented to sick kids. She was actually, she's now a 4-year-old girl. She's Native Canadian. She's from one of these small populations in northern Canada called Moose Cree. One of the small number of Indigenous patients that we do follow. And she developed at birth, she had microcephaly, retinopathy, infantile spasms, and developmental delay. However, she also had GI symptoms. So she developed bloody diarrhea around 7 months of age with vomiting, anemia, and perianal disease. She did have immune deficiency with urosepsis, skin infections, and eczema. She had other features such as wide-spaced nipples, a bifid uvula, and as most of our patients, her immune workup was negative, at least the preliminary workup that was done at sick kids. And unfortunately, her gut disease was quite severe. So by 2 years of age, she actually had uncontrolled colitis, did not respond to any biologic therapy, and required an urgent colectomy to basically resolve her severe disease. So we did whole exome sequencing of this patient. This was done by a PhD student named Sinai, and he found a homozygous variant in a candidate gene, integrin alpha V, that was rare, quite damaging, and not found in any of the databases. So as many of you know, integrin alpha V is an important integrin. It's involved in binding a number of beta, so beta 1, 3, 5, 6, and 8, and probably it has a number of different ligands and soluble ligands, but probably most famously known for its regulation of TGF signaling, which Daniel has already discussed. So interestingly, our patient had brain, eye, muscle, skin, liver, and GI disease, very similar to what you see if you knock out ITGAV in mice, which is embryonic lethal for most mice, which brain hemorrhaging, retinopathy, and a very similar colitis. Also, as Daniel mentioned, it's similar to what he sees in his patients with TGF beta 1 deficiency, also similar to what we see overlapping with Lolodits. And then interestingly, in mice, ITGAV has been knocked out in almost every hematopoietic cell line. And what we know now is that the colitis the colitis that these mice actually get is most likely driven to the alpha V's role in macrophage neutrophils and dendritic cells. Also, it has an important role in more typical or polygenic inflammatory bowel disease. There have been a number of SNPs and ITGAV and ITG beta 8, and one of the binding partners that have been identified as risk variants in GWAS studies. And what's been most exciting is that there have been a number of novel autoantibodies that focus on the alpha V beta 6 that have been identified in patients with ulcerative colitis prior to getting disease, and also with severity of disease from a Japanese study. So interestingly, we thought that this missense variant actually caused a functional defect, and we spent a few years trying to identify what that was and had no luck. But after going back and looking at the sequencing data again, we were able to identify that the actual missense variant actually produced a novel splice acceptor site. And the Shishimi plot shows that this novel variant actually drives novel splicing, missing when you're actually splicing out of exon 3 into exon 4 with a novel stop codon. And we can see from fibroblasts from the patient that they lost all protein expression of ITGAV, and the message was also reduced. So as Daniel mentioned previously, TGF signaling is quite interesting. TGF is produced, it's cleaved, and then you have this long latent protein complex that actually is into the extracellular matrix, and it binds to alpha V, and then you need stress on your cell, and this releases TGF for its anti-inflammatory properties. But we were able to show through bulk RNA sequencing from patients' fibroblasts as well as lymphoblastoid cell lines that different components of TGF signaling were downregulated. We were also able to show that the extracellular matrix and we were able to show that the connections were actually made, but ITGAV was reduced in our patient fibroblast cell line and at focal adhesions, and also the TGF signaling was reduced both through SMAD signaling as well as immunoblotting of patient cell lines, patients' biopsies from the colon, where we had reduced total SMAD3 positive staining. Interestingly, we identified a second patient, and this patient was from Paris, also had a highly damaging high CAD score mutation variant. This patient had a less severe phenotype with developmental delay, eye disease, hyper IgE, and eosinophilia, lots of atopy. As you can see here, this is the allergy panel, which almost everything showed up as being allergic. And severe IBD, which was also very difficult to treat, did not respond to any biologic, and is heading towards colectomy at this point. In this patient, we actually identified another novel mutation, and what's interesting is that when the alpha and the beta are actually processed, it's processed in the ER, and they must bind together before they're transported to the plasma membrane. And this variant, and that requires 4 calciums, and this variant actually caused a reduction in one of the calcium binding sites. And therefore, we were able to see that the protein actually was stuck in the plasma membrane, not transported to the membrane correctly, at least some of the protein. And this would explain probably the intermediate phenotype that we see in this patient. And then a third family, we identified a Dutch family where there were multiple brain abnormalities. And unfortunately, 4 to 4 fetuses were terminated due to severe neurological defects. And in this scenario, we identified 2 splice defects that also resulted in probably no protein being produced. So we made knockout zebrafish of ITGAV, and similar to what we see in the mice and humans, they had most of the zebrafish die, but the ones that survived had brain bleeds as well as gut abnormalities. We did bulk RNA-seq again in this, and interestingly, we identified a number of interesting factors. We saw in the eye that the fish actually had loss of vasculature compared to wild type. But in the brain, we saw actually a loss of microglia. So the number one protein that was reduced in the bulk RNA sequencing was a microglia marker. And in our knockout fish, we actually see that the fish do not have any microglia, which could explain the brain defect if microglia are not present for any injury repair. Also in the gut, we were able to show that the mice that did survive to juvenile fish, a small percent of them, they were actually smaller in weight and height and BMI, and the survival was actually quite reduced. And they had using bulk RNA-seq, we were able to show that they had inflammatory cytokine elevated, and also had decreased SMAD signaling, again indicating that the gut disease is being driven again by TGF signaling in these fish. So this again is another novel monogenic inflammatory bowel disease. Like many of our patients, it is systemic disease with a number of different features. It's characterized by brain, gut, retinal defects. And our zebrafish showed the loss of microglia, retinopathy with lots of vascularization, as well as severe colitis that we think is due to SMAD3 signaling properties. So this now sort of indicates that the TGF signaling pathway is critical for a number of these different diseases. So move on to a second case. This is another severe form of IBD that was brought to our attention by one of our collaborators in China, Dr. Ling Wang. And this was really a multi-centered study with Home Ulig and Con Bostak in Austria, as well as a number of other collaborators around the world. So this patient actually was presented in Luxi, China. She had severe colitis. This is her colonoscopy. You can see on the right, this is quite severe, really as bad as you can get, inflammation throughout the gut. In this patient, presented as a non-consanguineous Chinese patient, presented at 2 weeks of life with fever, whole body rash, and her endoscopy quite showed ulcers, which produced a quite severe colitis. And unfortunately, she died by her third birthday, and it's unclear the reason why she died. At the same time, at Sick Kids, we identified a second patient from non-consanguineous Jewish parents. The dad was adopted and presented 2 weeks of life with a similar phenotype with skin rash, diarrhea, elevated inflammatory markers. Her scope showed colitis that progressed to quite severe colitis. She also had a vasculitis and basically failed numerous rheumatologic as well as gastroenterology biologics. By 15 months of age, she really had severe arthritis and severe colitis. And interestingly, we sequenced her family. Initially, there was no family history, but we identified, and dad actually had a very similar disease beginning in childhood, where his disease progressed quite severely as a young child, and he was diagnosed with immune deficiency, but as an adult had this bowel, skin, and joint disease with elevated fever and CRP. And he was sort of told, to live with these sort of symptoms that he had that were not so severe, but really did impact his quality of life. So in sequencing these two patients, both from China and Canada, the two families, we identified mutations in SYK-SYK. Interestingly, the patient from China and Canada both had mutations at exactly the same amino acid, the 550 amino acid, but different changes in amino acid. We also had a patient from Austria, Hungary identified by Con, a patient from the UK identified by Home, and a patient from Freiburg identified by Boder Grimbacher. These patients, the bottom three patients presented as older, and one as a 12-year-old and two as adults, and two of the patients presented with mostly with lymphoma. So as you all know, SYK is a very interesting molecule. It's really known as an adaptive immunity in its role in ITAM signaling, specifically in B and Fc cell receptors. Its homologue ZAP70 is in T cells, but it also has an important role in innate immunity, where it's involved in fungal recognition in this dectin signaling pathway. And it is druggable. There are a number of drugs, small molecules that target the kinase activity of SYK. So interestingly, in our patients, patients 1, 2, and 3 are the first patients with the mutation of 550. They presented early in infancy with quite severe disease, and all these patients had rheumatoid arthritis, dermatitis, inflammatory bowel disease with B cell defects. But the older patients presented with this more diffuse large B cell lymphoma and a variety of different symptoms, including CNS, liver, and liver disease. So SYK is interesting. We know that it's held in this closed conformation. It then becomes activated, it opens up, it autophosphorylates and is activated. We were able to identify that the SYK gain of function mutation was gain of function, and it resulted in tonic or ligand independent signaling. So we can see here, these are PBMCs from our patient, that phospho-SYK is activated. And this was done by showing that all the variants were hyperactivated in a number of different methods. We were also able to show in the gut that SYK was hyperphosphorylated, and this resulted in increased phospho-SYK and secretion of inflammatory cytokines to fungal and bacterial wall MAPs. And also we know that there was a candida dysbiosis in our patient from China. One of our collaborators, Dali Li, made a knock-in mice of this human variant, the 550, the severe disease. And these mice, interestingly, were unable to hold. So mice should be able to hold on indefinitely, and our mice at 5 weeks were unable to hold on to the cage, which indicates, again, some joint issues or systemic disease. He was also able to show that the mice had inflammation in both their paw as well as their tail, and had these quite significant erosions in the joints of their paw as well as their tail. He then was able to do bone marrow transplant studies that were able to show that if you put sick variants into wild type, this actually caused disease. Again, showing that the immune component was driving disease, and the opposite. If you put wild type into the sick mice, this resolved the arthritis phenotype. So we were quite excited. We were able to show that our first patient, unfortunately, we weren't able to help, but our second patient actually had bone marrow transplant and was cured of her disease. And this is her now, a few years post-transplant, doing normal things. A number of our patients have been treated with a SYK inhibitor. It can't be used in pediatrics because of a black box warning due to cartilage defects. And we have seen some short-term improvement. And we also know there's a B-cell lymphoma risk and probably other cancer risk in a number of these patients. So this is a novel new disease. This is one of the Sick Kids ads where we're showing that this patient has now been cured of her disease. In a follow-up study, we've identified 20 novel patients from around the world with these with novel Sick variants, and we really expanded the phenotype of what we see in these patients. And just to close for the last few minutes, just to quickly discuss TT7 deficiency. So many of you would know TT7 deficiency is quite an extreme disease where the patients present with really severe intestinal disease. And you can see TT7 is expressed throughout the bowel, throughout all sections of the intestine. And it's really, it has a very peculiar phenotype where patients will get this severe atresia that recurs, as well as T-cell abnormalities and apoptosis in the gut. So our group was one of a few groups that identified TT7 deficiency. And if you make organoids as Daniel mentioned before, the organoids actually grow inside out. So there is a polarity defect. And our group has spent a lot of time trying to understand really the mechanism of disease and the biology behind this. And we know that it's involved in PI4K signaling. Interestingly, patients with biallelic variants in PI4K have a severe neurologic disease, but they also have a very similar intestinal disease. And we've also identified mutations in UBR5, which interacts with T7, and these patients also get severe inflammatory bowel disease. So we think this mechanism is broader than just TTC7. So unfortunately, what we know is that most of these patients die before 2 years of age. There's two clinical phenotypes. There's the immune defects as well as this gut phenotype. Bone marrow transplant in these patients provides short-term cure, but then the disease usually comes back in the gut quite severely after a year or so post-transplant, and the patients have severe morbidity, and often they will die from their severe gut disease. So we did a project where we actually we basically looked for FDA-approved molecules through a drug screen and identified a single drug that seemed to improve the apoptosis phenotype through our cellular models. This was validated in zebrafish and also validated in human organoids from one of our patients. And quite excitingly, now we are doing an N=1 style trial. We've identified 10 patients at this point, and of these patients, the majority of these patients have had some improvement. It seems to work better with the milder phenotype, which is just the IBD and apoptosis. But we do have one patient from Argentina who presented at birth and had severe TT7 deficiency, was started on leflunomide very early on, and has basically been able to, with no surgery, has been able to have a good quality of life without progression of the disease on leflunomide. So we're hoping, and Jonathan O'Donnell, a new MD fellow in the lab, is working on a case series now to present this data. So I think I'm just going to skip this part. And I think what's been exciting, as Daniel mentioned, from their first discovery with IL-10 defect a number of years ago, this sort of monogenic intestinal disease has now been proven to be a real entity, and now a standard of care for most countries in Europe, Canada, and the US, where it's very easy to get sequencing for a number of our patients, where prior to that it was very difficult to make the diagnosis for any of our patients. So overall, we're working in precision medicine. It's a work in progress. These are a number of our kids who have had a diagnosis of monogenic intestinal disease, had transplant, are now cured of their disease. And just to thank our collaborators, as Daniel mentioned, funding through the Helmsley Charitable Trust, as well as congenital diarrhea, enteropathy, our patients, the funders, and the students have done all this work. So thank you.
Thank you very much for your brilliant talks. Maybe I would move on to the Q&A session because we already have one question in the chat from Bodo Gimbracher. He refers to Daniel's talk and he asks if heterozygous RIPK1 individuals have a phenotype, and if so, which? Have you looked?
Thank you very much. Great to meet you, Bodo, even though I cannot see you. There are individuals that have been reported with heterozygous RIP kinase 1 defects. In principle, this is a very specific mutation that leads to a defective cleavage of RIP kinase 1. So it's basically at the position D324. And these patients develop a periodic fever syndrome, so an autoinflammatory syndrome. In terms of all the other heterozygous individuals, yet we could not observe a phenotype like, so parents stay healthy, so rather following a biallelic mode of inheritance. Does that address your question?
I think so. I may have a question from the family perspective. What advice would you give to families navigating the genetic implication of monogenic IBD, such as risks for other siblings? I don't know who would answer that.
Oh, sure. So I think if you do have a family member with monogenic inflammatory bowel disease, you need to see a genetic counselor, because they're, depending on what the variant is and what the heritability is, that there would be risk for other children or other family members. So that would definitely be needed to have counseling at this point.
Thank you. And I have another one. Are there any red flag that a pediatrician or GPs should look for to refer a patient for further testing?
You want to address, Alex?
So go ahead, Daniel. That's great.
So as a red flag, I guess, unfortunately, we cannot really define the a conclusive risk stratification where you say you need to have genetic testing. But there are certain risk factors. The most common risk factor is age. So that's why we are talking about patients with a very early onset inflammatory bowel disease. So patients below 6 years of age. Of course, there's a higher risk if you develop the disease even earlier in infantile stage. But still, you should consider monogenic diseases and genetic testing in patients if there are other, as I have mentioned in my summary, comorbidities, family histories, autoinflammatory, autoimmune phenotypes, extraintestinal manifestations, and so on. And of course, whenever you have that feeling that something does not go the right way, so meaning that a patient is refractory to standard treatment.
And if I may, I have a last one. And is it easy to access the diagnosis, and especially genetic testing?
Yeah, so it used to be very difficult to get genetic testing, but thanks to the work of a lot of people around the world, especially Home Lulik and Daniel and his team, I think it's become more standard of care. So most places in Europe, I think, if some of the symptoms that Daniel mentioned, we're able to get testing done quite quickly. Part of the difficulty is interpreting the testing. Often you'll get back a variant of unknown significance, and that often will require collaborating with a lab that does some of the functional studies. But hopefully getting the testing and things like Daniel mentioned, IL-10, the most common variants, people are able to identify those quite quickly and get the appropriate therapy.
And as Alex has mentioned, I guess, like, just to give you an example, in Germany, we have pushed basically genetic diagnostics also as a clinical routine testing, which will be covered by also, at least in part, by the insurances now, based on our data.
Thank you.
I think we have a question from Klaus Gilitzer asking, how do you decide to perform a colectomy on a patient having a severe perianal disease, which could be more Crohn than CU? So how do you decide this surgical strategy?
I see that question is directed to me. So that's a difficult question. So it never is black and white. So sometimes, unfortunately, our patients, there's no choice. You need to go to surgery because of a severe inflammatory bowel disease and the microperforations or the amount of inflammation within the gut. And once prior to biologics, that was quite common even in Crohn's disease. And often patients with severe neurologic complications, a colectomy is transforming for them because you can actually reduce most of the disease burden and increase quality of life. But it never is a very easy decision, especially if there is a thought that this may be more Crohn's-like than an ulcerative colitis.
So maybe another really last question. So great talk. So does microbiota dysregulation play a role into the expressivity or penetrance of this monogenic IBD? Do you have any clues on this?
So maybe I could just start and Alex can close. So definitely the microbiota plays a role. If you remember the Venn diagram that I have shown, it's a very critical point, still very difficult to study and to really pinpoint which microbiota you should and how to influence it. But for sure, it plays a very important role because we see that there are certain differences in manifestations even among siblings, as I've shown for MD2, for example, where we have one patient that developed more an IBD phenotype, while the other showed rather recurrent severe infections. So there is, it definitely plays a role in expressivity and penetrance, and it needs also to study it in greater detail, but it's not as easy to do.
Well, I think
and
we
there are a
have
lot
now
of monogenic diseases that that are basically falling into that category of defective bacterial handling.
I think we have now reached the end of the webinar. So on behalf of the ERN-RITA, we would like to say one thank to you guys, Daniel and Alexio, for this excellent session and for the discussion that followed. So thanks again for attending the Tuesday Lunch with Rita webinar. So before we go, please note that the next Tuesday Lunch with Rita on February will be on regarding VEXA syndrome. So please join us again next month. And have a good start in the year. And bye-bye. Thank you, all of you, and as well, Martin and Julia, for sharing the session. Bye-bye.
Thank you very much for having us and for coordinating it.
Very good.
Bye.
Bye-bye.
Bye.
Bye.